Hi, this is Dr. Bhargava. This next video is in the series Body Imaging Case Review, and I have multiple interesting cases to share with you all. This is our first patient, and on this coronal image from their CT of the abdomen and pelvis and bone windows, we find some interesting findings. One is this calcified spleen and other fish mouth appearance of vertebral bodies, and they both point towards sickle cell disease. This is our next patient, and we performed two views of the chest. Here the finding is in the pleural space. So in the left costophrenic angle we see that it is sharp, and on the right side we see that there is some blunting, and on the lateral view we find the same blunting right here of the costophrenic angle on the right side. Here is the left hemidiaphragm that we lose as we come closer to the heart border. That's the silhouette sign, and the diaphragm that continues all the way to the anterior chest wall is the right hemidiaphragm. And so this patient has a small right-sided pleural effusion, and we just went over how to recognize it on the frontal and lateral views of the chest. This is our next patient. We are looking at multiple images from their whole body FDG PET CT scan. Let's start by looking at the rotating image. Looks like they have this large FDG avid tumor in the right lung, and so they were diagnosed with lung cancer. This is their tumor, which is hypermetabolic. And the interesting finding here is that because there is a lot of background FDG uptake in the brain, it's hard sometimes to recognize lung mets. And so this lung met is slightly calcified that we see here on the CT that was performed as a part of the PET CT, low dose, non-contrast enhanced, and we find that there is no focal hypermetabolism that is visualized on these fused PET CT images. This is their contrast enhanced image from their MRI of the brain showing the metastatic lesion. So FDG PET CT is not good for diagnosing brain mets, and these patients, especially the ones who are newly diagnosed with lung cancer and melanoma, they undergo a MRI of the brain with and without contrast to rule out metastatic disease to the brain. Here's our next patient, and these images are from their CT scan of the abdomen and pelvis at two different time points, and these were acquired prone to evaluate a urinary bladder stone. And so prone imaging is very helpful when on supine imaging we are unable to differentiate between a stone that is stuck at the UVJ or a stone that is actually inside the lumen. And so when you do prone imaging, the stone becomes dependent and it's seen like this. And on serial imaging, we have followed that the stone has become larger over a period of time. Here's our next patient, and we find that they have this enhancing tumor in the retroperitoneal space, also seen right here and here. This turned out to be a paraganglioma. Here is our next patient. We have performed a DOTATATE PET CT to evaluate a neuroendocrine tumor in this patient, and we find that there are multiple foci of increased uptake in the abdomen and pelvis. And this was secondary to peritoneal metastases from a previously resected small bowel carcinoid. This next patient was diagnosed with a cervical cancer, and we performed initially an MRI of the pelvis, and we are looking at multiple images from that study. This is the uterus, and in the region of the cervix we see this T2 slightly hyperintense tumor, and on this axial image we find that there is bilateral parametrial extension at those levels, and also seen here parametrial extension and some metastatic lymph nodes in the left side of the pelvis. And so this patient should get an FDG PET CT for whole body staging before a treatment plan is decided. So this is a great example of a locally advanced cervical cancer seen on the MR of the pelvis. Here is our next patient, And I'm showing you two images from their CT of the abdomen and pelvis without contrast. And on the axial image, we find that there is diffuse fat infiltration of the liver. It's hypodense, so there is fatty liver. But at the same time, there are nodular areas that are slightly hyperdense. And so these findings suggest focal fat sparing, or the regions, nodular regions that are not infiltrated with fat. And so focal fat infiltration can be seen as round or regional or geographic. Similarly, focal fat sparing can be seen as round, regional, or geographic. Here is our next patient, an 88-year-old male complaining of pain in the left thigh. We performed a CT scan that shows this large solid tumor around the left proximal femur, and there is a fracture seen here. There's bone fragmentation, and on the bone windows we find that the architecture of the bone is not normal. It's sclerotic, and we see the same finding here on this coronal image. This patient underwent surgery, first biopsy where they found lymphoma, and then we performed a whole body FDG PET CT for staging. Here's the rotating image. So there is a large hypermetabolic mass involving the left proximal thigh, and it is also seen here. Looks like they've had surgery because there is an intramedullary rod there. And there is another focus here in the upper abdomen that is likely lymphomatous involvement also, and some post-surgical changes in the region of the hip. This turned out to be a diffuse large B-cell lymphoma, and the patient was treated with chemotherapy after their surgery. Here is our next patient, and on the contrast-enhanced CT of the abdomen and pelvis, we find that the kidneys are not present in the retroperitoneal space on either side, but there is one fused kidney in the pelvis, which is seen right here and also here on the sagittal image. And so the diagnosis here is fused kidney in the pelvis, which is also called pancake kidney. And when there is an anatomical abnormality like this, we have to pay attention to the arteries that supply the kidney, the veins that drain the kidney, and also comment on the ureters if one or both ureters are seen, and what is their course and how do they insert into the urinary bladder. And so remember that whenever there are congenital abnormalities of the kidney, pay attention and report the arteries supplying that kidney, the venous drainage, and the appearance of the ureters. Here is our next patient. We are looking at a single frontal view of the chest. They have an NG tube. They have a right-sided internal jugular dialysis catheter, and on the left side also they have an internal jugular venous catheter that goes directly into the right atrium without crossing over into the SVC. And so this is a great example of a persistent left-sided SVC, also seen here on their CT scan coronal images showing the persistent left-sided SVC. This is a congenital abnormality that is seen once in a while in our patients, but it's important to report it. Here is our next patient. They had two different studies at two different time points, and these studies are a CTPE protocol. And in the prior study, we find that they have filling defects in the pulmonary artery branches, suggestive of acute pulmonary embolism. And on the follow-up study, which was the current study evaluated, it's very important to compare with the prior study and go level by level to look at resolution of previously seen filling defects in the pulmonary artery branches. And that is important to find if there are any new filling defects in pulmonary artery branches that were not present before, to make the diagnosis of a new acute pulmonary embolism as it was in this patient. Here is our next patient, and they were diagnosed with gastric adenocarcinoma, and they presented for a CT scan of the abdomen and pelvis, where we see that they have a large volume pneumoperitoneum, also seen here, and there is a perforation secondary to this tumor involving the greater curvature of the stomach, also seen right here. So gastric perforation from a tumor and development of pneumoperitoneum, and also large volume ascites. This is our next patient, where they presented with abdominal pain, and on their CT of the abdomen and pelvis, we find that there is a large gallstone present in the gallbladder. The gallbladder is not distended, but the wall is thickened, irregular, and shows enhancement. And so this patient does not have acute cholecystitis, but because of these findings in the gallbladder, we have to make a diagnosis of chronic cholecystitis, and it looks like they have some enteritis as well. So looking at the enteritis in their pelvis, there are small bowel loops that show mural thickening, hyperemia, prominent enhancement, and some surrounding fat stranding. So these findings are classic for enteritis or small bowel inflammation. This is our next patient. They were diagnosed with pancreatic adenocarcinoma. We have performed a CT of the abdomen and pelvis, and the tumor is right here, and it's abutting a portion of the portal vein and is encasing a part of the SMA that would make this tumor unresectable. That is also seen right here, the SMA being encased by this hypodense pancreatic tumor. Here's the tumor, and this is the encasement of the proximal SMA. This is our next patient. They underwent a carotid ultrasound, and on the right side, looking at the vertebral artery, the flow is antegrade, but on the left side, looking at the vertebral artery, the flow is retrograde. And compared to their prior CT in the system, we find that the left subclavian vein is occluded with a thrombus. So this is a great example of a subclavian steal. Here's our next patient. They presented with postmenopausal bleeding, and we've performed a ultrasound of the pelvis. Here we are looking at the uterus, and this is the heterogeneous endometrium showing some cystic changes, which are hypoechoic right there. It is thickened 1.4 centimeters in thickness, and on the right we have two images from their ovaries, which are very small. And so that goes along with their postmenopausal status. And so something like this should be biopsied to rule out an endometrial cancer. This turned out to be an endometrial cancer. This is our next patient. They presented with abdominal pain, and a multiphasic CT was performed to evaluate for a suspected liver abscess. So we have non-con, arterial phase, portal venous, and delayed images. And on the portal venous phase, we see this very large multiloculated hypodensity with thick, irregular, enhancing walls and some incomplete septations. And these findings are very characteristic of an abscess. They were treated with antibiotics, and a percutaneous catheter was placed inside this abscess to drain the pus. Here is our next patient, and they underwent a whole body FDG PET CT. The interesting finding here is incidental, which is this focus of mild hypermetabolism at the inferior border of the left scapula, corresponding to this soft tissue density. And this is a classic boards question. The diagnosis here is elastofibroma dorsi, abnormal soft tissue density, frequently unilateral, could be bilateral also, at the inferior pole of the scapula, and it is a soft tissue density on CT and may show mild to moderate hypermetabolism on FDG PET. There is also some atelectasis seen here in the right lung base, and that is also seen right here on this rotating image. Thank you for watching.